Hello everyone, welcome to Alacrity Explains Anatomy. Today we are going to be looking at fetal circulation. Please don't forget to like this video. Don't forget to subscribe to the channel. It helps the channel. Don't forget to share and comment your thoughts in the comment section. Thank you. So let's look at fetal circulation. So the fundamental principle in fetal circulation is that the fetal lungs are collapsed and fluid filled, so they are non-functional for gaseous exchange. The fetal lungs are non-functional for gaseous exchange. The placenta serves as the sole organ for respiration, nutrient delivery, as well as waste removal for the fetus. Therefore, the fetal circulatory system is designed to bypass the pulmonary circuit because the lungs are non-functional. So it is designed to bypass the pulmonary circuit while perfusing the developing lung tissue with just enough amount of blood for growth. So oxygenation of blood occurs at the placenta, not at the lungs. So the fetus relies on three key shunts to route blood efficiently. We have three key shunts that help to route blood efficiently in fetal circulation. So if you look at this image here, we have our placenta here, we have the umbilical veins as well as the umbilical artery, we have the umbilical cord, as you can see here, contains the umbilical artery and umbilical vein. And on this side we see how blood moves from the placenta, goes in this direction, gets here, and if you take a more expanded view of this, you will see that we have blood coming in here, going this way, and like this, we're having access to the inferior vena cava, then to the heart, then from here into the right atrium, moving from this into the left atrium, and from here you have some blood entering here and going here, and blood here is bypassed, and that way we then have blood coming back here and meeting here to good system circulation. So we're going to look at all this in this video. So what are the essential fetal shunts? The shunts are the ductus venosus, foramen ovale, and ductus arteriosus. Ductus venosus, foramen ovale, ductus arteriosus. The ductus venosus connects the umbilical vein to the inferior vena cava. Please don't forget any of these facts, they are all important. The ductus venosus connects the umbilical vein to the inferior vena cava, so it bypasses the liver sinusoid, unlike in the adult circulation, right, where blood has to goes through the liver. In the fetus, the ductus venosus helps to bypass the liver sinusoid. We now have the foramen ovale, which is an opening in the interatrial septum and in the septum between the right atrium and the left atrium. So in fetal life, there is an opening between the right atrium and the left atrium, which is not the case in a normal adult, right? So this foramen ovale, it shunts blood from the right atrium directly to the left, thereby bypassing the right ventricle and the pulmonary trunk, because in the adult we know that blood moving from the right atrium has to go to the right ventricle, then passes through the pulmonary trunk to the lungs. But in fetal life, we know that the fetal lungs are non-functional, so the blood is moving from the right atrium directly into the left atrium without going through the right ventricle and pulmonary trunk, though a little amount of blood passes there, which we said is to supply the developing fetal tissue, just enough for its growth. So we have the ductus arteriosus, which connects the pulmonary trunk to the descending aorta. Remember, connects the pulmonary trunk to the descending aorta. We already said that little amount of blood goes through the right ventricle and the pulmonary trunk. So that little amount of blood that gets to the pulmonary trunk, if there is a situation where this blood is too much, the blood will be bypassed through the ductus arteriosus, bypass the non-functional lungs by shunting the blood from the pulmonary artery into systemic circulation, from the pulmonary trunk into the descending aorta. So this is what you have generally. This is our placenta, this is our umbilical cord, this is our umbilical artery, this is our umbilical vein. So the umbilical vein now carries the blood, right? It carries the blood. So we have the umbilicus here. So umbilical vein carries the blood. Instead of going to the liver sinusoid, it bypasses the liver and enters the inferior vena cava. It bypasses the liver and enters the inferior vena cava. In the inferior vena cava, it gets into the right atrium. In the right atrium, instead of moving to the ventricle, the right ventricle, it bypasses the right atrium into the left atrium through the foramen ovale. So from here, a little amount of blood, we say, enters the right ventricle and goes through the pulmonary trunk to the lungs. Now, little amount of this blood is supposed to supply the lung tissues, as we can see here. Why, if it is too much, some of this blood is bypassed from the pulmonary trunk into the descending aorta, as you can see in this image, and the blood comes back like this, supplies the tissues of the fetus, and through the hypogastric arteries goes back through the pulmonary arteries and gets back to the placenta for oxygenation. So this is the whole route generally. So the umbilical vessels, we have one umbilical vein. Take note of that. There's only one umbilical vein and there are two umbilical arteries. High yield fat for MCQs. One umbilical vein, two umbilical arteries. The umbilical vein carries highly oxygenated blood from the placenta, carries highly oxygenated and nutrient-rich blood from the placenta to the fetus. Excuse me. While the umbilical arteries carry deoxygenated blood from the fetus back to the placenta for oxygenation. So the memory trick is, just look at it this way. Arteries go away from the heart, right? We already know that arteries go away from the heart. So take it that in fetal circulation, they go away from the fetus. Arteries go away from the heart normally in the adult. Take it that in fetus, arteries go away from the fetus towards the placenta. So the two umbilical arteries are carrying deoxygenated blood from the fetus to the placenta, away from the fetus. So that's it. So as you can see from this image, we still have our umbilical vein here, umbilical arteries bringing blood back, the umbilical veins taking blood up to the inferior vena cava, bypassing the lungs through the ductus venosus and back to the foramen ovale, where blood moves from the right atrium to the left atrium and continues to systemic circulation. So the pathway for fetal blood flow is that oxygenated blood from the placenta travels through the umbilical vein into the fetal abdomen. Now, a major portion of this blood bypasses the liver through what? The ductus venosus and enters into the inferior vena cava. Now, this oxygen-rich blood mixes with deoxygenated blood returning from the lower extremities in the inferior vena cava. So there's a mixing of the oxygenated and deoxygenated blood. So the inferior vena cava empties this blood into the what? The right atrium. Look at this image. We have blood from here, from the umbilical vein, going up, oxygenated and nutrient-rich blood. So it bypasses the liver here, as you can see. It bypasses the liver. And there's another blood coming from the lower limbs, lower extremities, through the inferior vena cava. This blood is deoxygenated. So there's a mixing of this blood here with the blood from the umbilical vein. Now we said the blood from the umbilical vein bypasses the liver sinusoids through the what? The ductus venosus. The ductus venosus shuns oxygenated blood from the placenta away from the semi-functional liver towards the heart. Now, as it gets to the right atrium, within the right atrium, there are two streams of blood meet. There's a highly oxygenated blood, IVC stream, and a poorly oxygenated superior vena cava stream. So we have blood from superior vena cava and inferior vena cava all coming to the right atrium. So the anatomical flap, that's the septum secundum, we'll look at the biology of the heart in subsequent videos. So the anatomical flap which separates the right atrium from the left atrium, there is the anatomical flap directs the IVC stream, blood from the inferior vena cava, preferentially towards the foramen ovale. So preferentially, blood from the inferior vena cava, which is highly oxygenated, is directed towards the foramen ovale. So this oxygen-rich blood passes through foramen ovale into the left atrium from This is foramen ovale here you have here. The foramen ovale allows oxygenated blood in the right atrium to reach the left atrium. So there's blood in the right atrium, a mixing of oxygenated and deoxygenated blood. So this blood, the oxygen-rich stream is going to bypass the right atrium into the left atrium directly without going through the right ventricle. So from the left atrium, it goes to the left ventricle and is then pumped out through the ascending aorta to supply the coronary arteries, the brain, upper extremities, the most oxygen demanding organs. So blood is moving from the left atrium here to the left ventricle and is being pumped out through this direction into the aorta to supply the organs of the body, oxygen dependent organs of the body. So that is that about the right to left shunting through the foramen ovale. Remember we said little amount of blood goes through the right ventricle. We'll talk about that amount of blood soon. So the second shunt, which is the ductus arteriosus. The ductus arteriosus now is bypassing the lungs. Now blood that remains in the right atrium from the superior vena cava, which is poorly oxygenated, and the coronary sinus now passes into the right ventricle. Remember we said a little amount of blood, which is this is what we're talking about now, passes into the right ventricle and is pumped into the pulmonary trunk. This is the pulmonary trunk. As you can see here, this is our pulmonary trunk, pumped into the pulmonary trunk to go into the right and left lungs, right? Good. Now as it's pumped into the pulmonary trunk, because the fetal lungs are collapsed and have extremely high vascular resistance, only a tiny fraction, about 10% of this blood goes to the lungs. Only a tiny fraction, about 10% of this blood goes to the lungs. Instead, most of the blood from the pulmonary trunk is diverted through the ductus arteriosus. Look at this. This is where we said the blood is coming from. Let me reduce some of these diagrams, these drawings. So we have this is blood from going to the lungs and supposed to go to the lungs here, right and left lung, and we are seeing only 10% of this blood gets there. So the remaining percentage of blood is shunted through this piece here. This is number 3, the ductus arteriosus. It connects the aorta with the pulmonary artery, further shunting blood away from the lungs to the aorta. So this part of this, the major percentage of the blood, 90% of this blood, is shunted from the pulmonary trunk back into the aorta to meet with this into the aorta, the descending aorta, right? Good. So that's what we have, back into the aorta. So this deoxygenated blood then perfuses the lower extremity and returns to the placenta through the 2 umbilical arteries for reoxygenation. Remember I said the umbilical arteries are 2, the umbilical vein is 1. So that's what happens. Blood comes in here through the IVC and the SVC, mixes here, oxygenated blood, highly oxygenated blood follows this route into the left atrium, from the left atrium to the left ventricle, from the left ventricle through the aorta to supply oxygen dependent tissues. Poorly oxygenated blood passes from the right atrium to the right ventricle, pulmonary trunk, about 10% goes to the lungs to perfuse the developing lungs for growth, and about 90% is shunted through the ductus arteriosus into the descending aorta to supply the lower extremities. So pressure gradient difference. Now most of the changes, this movement of blood, is as a result of pressure gradient. Now in fetus, the pulmonary vascular resistance is extremely high due to the collapsed lung. The lungs are collapsed, so the resistance in the blood vessels is very, very high, and hypoxic vasoconstriction. So consequently, the right ventricular pressure, which means the pressure in the right ventricle, is higher than the pressure in the left ventricle. The pressure in the right ventricle is higher than the pressure in the left ventricle. This is because of the pulmonary vascular resistance. The resistance the right ventricle has to overcome to pump blood. So there's higher pressure in the right ventricle. Foramen ovale is a foramen between the right atrium and the left atrium, like we said. So right atrial pressure slightly exceeds left atrial pressure, keeping the valve open. That's the reason why we say when the blood comes in, it's coming from the right atrium, and from the right atrium it bypasses the right ventricle and goes from the right atrium directly into the left atrium. So the pressure in the right atrial pressure is slightly higher than the left atrial pressure. That's the reason why this valve is open. The moment the pressure in the left atrial pressure becomes higher than the right, the valve closes. We'll talk about that later. So we have the ductus arteriosus, where the pulmonary arterial pressure exceeds the aortic pressure, driving flow from the pulmonary trunk into the aorta, because there's a pressure gradient, so it moves from the region of higher pressure to region of lower pressure. Then we have the ductus venosus. It's a sphincter in the ductus venosus preferentially directs oxygenated blood away from the high resistance liver. We have a high resistance liver, and there's a sphincter that directs blood from the IVC, from the umbilical veins, away from the high pressure or high resistance liver. So closure of shunts. These shunts has to close at birth. 3 simultaneous events trigger the switch to adult circulation. Remember, we already said the adult circulation is not the same as the fetal circulation. So there are 3 events that trigger the switch from fetal circulation to adult circulation. We have the first breath that the neonate takes. We have the clamping of the umbilical cord, and we have pressure reversal. We already talked about the pressure differences. So these pressure differences are going to reverse. So for the first breath, as the fetal lungs, the neonatal lungs are now functional. So the lungs expand with air. It takes in air because it can now function properly. So this causes a massive drop in the pulmonary vascular resistance we're talking about. So this drop in pulmonary vascular resistance due to mechanical stretch and increased oxygen tension, pulmonary blood flow rises 8 to 10 times. There's now increase in pulmonary blood flow to the lungs, increase in blood supply to the lungs, unlike when the blood had to bypass due to pulmonary resistance. There's now clamping of the umbilical cord. Now, when you clamp the umbilical cord, you remove the low resistance placenta circuit. The whole placenta circuit, the low resistance placenta circuit, is taken off. So this causes a sudden rise in systemic vascular resistance and a drop in venous return from the placenta. There's a drop in venous return from the placenta, so the pressure in the right atrium is going to now be lesser than the pressure in the left atrium. So this pressure reversal, the left atrial pressure now becomes higher than the right atrial pressure. So this increased pulmonary venous return to the left atrium now forces the septum primum against the septum secundum, functionally closing the foramen ovale. What did I say? Functionally, not anatomically. Functionally closing the foramen ovale. That is at birth. So at birth, the foramen ovale is closed functionally and not anatomically. So the fate of each shunt after birth. After birth, what happens to each of these shunts? What's their fate? What do they become? The ductus venosus constricts functionally within minutes due to increased oxygen and decreased prostaglandins. So anatomically, it becomes the ligamentum venosum. Take note of the spelling. Venosus here, venosum here. Ligamentum venosum. For foramen ovale, it closes functionally. I'm still repeating it. Foramen ovale, it closes what? Functionally within the first few breaths due to pressure reversal. Anatomically, anatomically fuses to become the fossa ovalis in the adult heart. Note, it is functionally closed at birth. As long as you see at birth, know that foramen ovale is functionally closed at birth, but it remains anatomically patent in about 25% of adults. We have the ductus arteriosus. The ductus arteriosus constricts functionally within 10 to 15 hours of life, driven by high oxygen tension and decreased circulating prostaglandins. So anatomically, it becomes the ligamentum arteriosum. Arteriosus in fetal life, arteriosum in adult life. Venosus in fetal life, venosum in adult life. So what are the clinical correlates? What are the things that can go wrong in this circulation? We have patent ductus arteriosus. Patent ductus arteriosus is failure of the ductus arteriosus to close after birth. When the ductus arteriosus fails to close after birth, there is a left to right shunt of blood. There is a left to right shunt of blood from the aorta into the pulmonary trunk instead of the other way around. There is a left to right shunting of blood from the aorta into the pulmonary trunk because of the high pressure now in the the aorta compared to the pulmonary trunk. So the classic finding is a continuous machinery murmur. So in case you see as given a clinical question, an applied question, and you hear machinery murmur, the moment you hear machinery murmur, what should come to your mind first is the patent ductus arteriosus. In utero, prostaglandins are essential to keep the ductus arteriosus open, that is in utero. Therefore, when maternal NSAIDs in late pregnancy can cause premature constriction of the patent ductus arteriosus. That's why NSAIDs are not advised in late pregnancy, because NSAIDs will cause an early closure or a premature closure of the ductus arteriosus. So surgeons also use NSAIDs, prostaglandins, when there's a patent ductus arteriosus. They give NSAIDs, prostaglandins, to try to help to close the patent ductus arteriosus. We have patent foramen ovale. Remember, we said the foramen ovale is in the right and left atrium. So it is failure of functional closure. Remember, we said at birth it is functionally closed. So when there's a failure of functional closure of foramen ovale, we call it the patent foramen ovale. And usually it is asymptomatic but can become a conduit for paradoxical emboli. In patent foramen ovale, there's going to be right to left shunting of blood, deoxygenated blood mixing with oxygenated blood. So likely to see the patient is going to be cyanosed. So this can also have a paradoxical emboli where a deep vein thrombus crosses the venous circulation into systemic circulation, causing stroke. And this is why patent foramen ovale closure is considered cryptogenic stroke. Patent foramen ovale closure is considered cryptogenic stroke. So we now have the transposition of the great arteries. Now, it's a congenital anomaly where the aorta arises from the right ventricle, which should not be so, and the pulmonary trunk arises from the left. There is a switching. So aorta arising from the right ventricle and the pulmonary trunk arising from the left ventricle. This is not so. So there is a switching of their position. So survival immediately after birth depends entirely on the patent ductus arteriosus and patent foramen ovale. In this situation, in transposition of great arteries, we need the ductus arteriosus and the foramen ovale to be patent to allow for mixing of blood. So prostaglandins are infused immediately to keep the ductus arteriosus open until surgical correction is done. So thank you for watching. Like and share, and don't forget to subscribe to Alacrity Explains Anatomy for more anatomy videos. Thank you.